So we want to welcome you to this occasion today. Our long-awaited guest of honor has arrived. Thank you, Dr. Mulwa, for gracing this occasion today. Standing before you, Elsa Odira. Elsa Odira is a program manager for health facility case management. How children are managed, or children under 5, the way they are managed in the health facilities, right from the dispensary up to the highest level of care. I coordinate what happens in those facilities. So this morning, this project here called Tmci, Tools for Integrated Management of Childhood Illnesses, is one strategy which I coordinate, what people normally know as IMNCI. But this is IMNCI, may I call it IMNCI Plus. We will hear about it when it will be talked. I also recognize the presence of Division, Dr. Caroline Mwangi. From the counties, I recognize the presence of Kakamega County, County Director of Health, Dr. Tieno, welcome, Phil at Pan-Africa. I recognize the presence of Kitui County, Kitui Muko. Yes, Kakamega Muko, they are there, watu wangu wa Ingoho. So, Washingishu is here. They are there. I also take recognition of other partners in the house who may for one reason have not recognized. I can see my dear sister, you are here. So we are all here because of the child. Turning on to PATH. PATH here is represented by the country director, Caroline Juguna, Tmci Global Project Director, Mike Rufo, welcome. And the PI, Nairobi University, has he come yet? Professor Machuki. Prof, meeting you. we were planning all this. Now, today I've met you. We have been exchanging emails. Huh? So this is the Elsa Odira you've been receiving mails from when we are planning and coordinating this thing. So all my colleagues from the research, University of Nairobi, you are here. Phil at Pan-Africa. So without much ado, I want to, because of time again, I invite my head of division, Dr. Caroline Mwangi, to take us through the program, welcome remarks and going down. Welcome, Dr. Thank you.
Jennifer. Oh, it should be a hotel.
Good morning, distinguished guests and colleagues. Elsa Odira has already welcomed you to this important event. Mine is to further reiterate the welcome and to appreciate the support that you have accorded us as the Ministry of Health, Division of Neonatal and Child Health, Department of Family Health. I am Dr. Caroline Mwangi, heading the Division of Neonatal and Child programs to reduce and morbidity of neonates.
Yes.
One such program.
Yes.
Go straight ahead to Africa Hub Director and Kenya, Caroline Juguna. Thank you.
This thing is it even working?
Hata tutakuwa tumechukua watu wetu. Thank you so much.
Hey. These people. Niulize Wamu, sasa hii vitu hujaweka nini?
Young infants aged 0 to 60 days. The first goal is to improve primary healthcare workers' ability to diagnose severe diseases by equipping them with pulse oximeters as well as decision support tools. The second goal is to accelerate the development and market entry non-invasive devices that augment the features of standard pulse oximeters with one or more additional vital signs measurements. Globally, the project is being implemented in 4 focus countries, namely Kenya, Senegal, Tanzania, as well as the Indian state of Uttar Pradesh. Here in Kenya, the project is being implemented in counties. That's Kakamega, Kitui, and Uasin Gishu. The Tmci project will work in collaboration with the governments in all the countries of implementation, as I've mentioned, India, Kenya, Senegal, and Tanzania, together with global partners to achieve the following. 1, as I mentioned, to introduce pulse oximeters and clinical decision support algorithms in over 300 primary healthcare facilities across the 4 project countries, as well as equipping healthcare workers with critical tools to detect severe diseases in children. The project also seeks to generate data on impact, cost effectiveness, and best practices for utilization of these tools within the primary healthcare settings, which then helps to address evidence gaps and form get product profile, market intelligence, and field evaluations, making severe illnesses detection even more robust. The project is and will collaborate with governments and financing partners to ensure sustainability and scale-up, connecting this work to the global progress towards stronger primary healthcare systems and universal health coverage targets. Lastly, in response to the COVID-19 pandemic in Kenya, The Tmci project, one, has provided technical assistance to the Ministry of Health to execute response plans. Through this project, we have supported training of over 600 health workers in the country. The Tmci project has also increased access to respiratory care systems to improve treatment of patients with COVID-19. In these respects, Tmci project has donated 89 pulse oximeters to 62 level 4 facilities in Kakamega, Kitui, Uasin Gishu, Busia, Nyeri, and Vihiga. The Tmci project is also assisting in the assessment and repair of over 150 respiratory care equipment in level 4 and 5 facilities in the 6 counties I've mentioned. Tmci is also currently assessing 5 PSA plants that's in Kenyatta National Hospital, Jaramogi Oginga Odinga Referral and Teaching Hospital, Migori County Referral Hospital, Nakuru Level 5, and PCH Chogoria Hospital, with a view to repair and service them over a period to increase access to medical oxygen. Here in Kenya, the project is working in partnership with the University of Nairobi in evidence generation activities that are focused on evaluation and analysis of pulse oximeters introduction that then informs future decision-making and the need for important operational learnings to improve implementation strategies. The project is also working with the national and county governments of Kakamega, Kitui, as well as Uasin Gishu to accomplish the following. 1, to introduce pulse oximeters and the electronic clinical decision support tools in 60 health facilities. The project in Kenya will also build the capacity of healthcare workers in 60 health facilities in the use of integrated management of newborn and child health, pulse oximeters, as well as the electronic clinical decision support tool and record keeping. In the 3 counties, the project will support and strengthen monitoring and evaluation of systems. And lastly, in Kenya, the project will also support logistics and supplies. Through this project, we are working with 3 civil society organizations from the 3 counties to sensitize caregivers, encourage care seeking and following of referral advice. In conclusion, the project team, the University of Nairobi, the national government, and the county governments have been working on the various preliminary activities to support implementation of the project, including health facility assessments, selection of sites, development of training materials, training of healthcare workers, developing and piloting the interventions, and by that I mean the electronic clinical decision support algorithms and pulse oximeters in the 5 health facilities in the 3 project counties. I wish to acknowledge all the stakeholders, ranging from the development partners, the civil society organizations, the academic and research institution, Ministry of Health at both the national and sub-national level, for going out of their way and collaborating and partnering in this project and supporting towards the launch of this project. With those few remarks, I wish to thank you and God bless you.
Before Dr. Carol comes in, just to have a rejoinder to thank you, Caroline Buguna, for that. Just to elaborate on what has happened so far, as she has mentioned about how children, the banner here tells us improving access to tools that detect severe illness. What that means is that we know when children are admitted in the facilities, if severity of illness is not detected early enough and intervention put in place, then they can die. Tmci is about being able to detect that a child needs oxygen now and oxygen is given. Tmci is about being able to detect hemoglobin, low hemoglobin level in the child, and blood transfusion goes in. Tmci is about being able to detect how severely the child is sick, and the correct intervention is put in place. So as we talk now, why we are here today, this is just a pre-event to the 12th November 2021 World Pneumonia Day celebration, which we will have on the 11th of November at a breakfast meeting somewhere. So the theme for this year is innovate, do something which is different to end childhood pneumonia. Pulse oximetry and the tools which again you will be taken through is just an innovation, a different way of doing things to be able to detect that. So I once again welcome you to this. And as we are talking, if you can just go to Facebook and YouTube, this is being transmitted live. So share. Sharing is caring, they say it like that. Eh? Biblically, if you share, you care. So share, we are online, Facebook and YouTube. Thank you. Dr. Caroline, thank you.
Yes, thank you, Elsa, for indeed reiterating that this is a build-up to our World Pneumonia Day, which is celebrated globally on the 12th of November, and we'll be marking it on the 11th of November. So in Kenya, we are tracking the use of pulse oximetry. It is in our outpatient under 5 register. So worker is supposed to take the pulse oximeter readings of a child and input it. But we do note, Director, that this is, the practice is low. So we want to encourage this practice and of course, treat and appropriately and promptly refer this child in case help is not available. So I'll now proceed to invite the Global Director for PATH, Mike Rufo, to make his remarks. Welcome.
Hi, everybody. Hello, I'm Mike Rufo. I'm the Global Director for the Tmci project, and I'm incredibly honored and grateful to be here. And thank you to the Ministry of Health for allowing this event to occur. And I also want to thank our partners that were alongside, leadership from Kakamega, Kitui, and Uasin Gishu counties, the University of Nairobi, Swiss Tropical and Public Health Institute, the civil society organizations that we're working with, along with colleagues from the WHO, UNICEF, Tmci, and everyone else that's here in person and on Zoom. And so, as Elsa mentioned, the challenge we're facing is that critical that they can be identified by the healthcare workers, and those healthcare workers can diagnose them or refer them without delay. To do that, healthcare workers need a lot of things, including training, but there are also tools that can help them.
No, today is yesterday to be here because yesterday we were not.
What our goal is to improve access to those tools that is often limited for many reasons, including demand, adoption, supply. There's a lot of barriers that we're trying to overcome. And so that's why PATH, with partnership and with funding from Unitaid, and in partnership with Swiss Tropical and Public Health Institute, and locally with partnership from the Ministry of Health, from leadership in Kitui, Kakamega, and Uasin Gishu, partnership with the University of Nairobi, and again, the civil society organizations, we're working to drive this forward. So the goal of the project is to improve access to affordable and appropriate tools to help healthcare workers identify critically ill children and refer them without delay. Very simply put. So how we're going to do that, and Dolo, our country lead, will describe in more detail how we're planning to do that. But very simply, we can say action, evidence, and innovation, which links to the World Pneumonia Day. So action, so we're equipping healthcare workers in over 300 primary healthcare facilities across the 4 project countries, Kenya, India, Tanzania, and Senegal, with the tools they need to detect severe illness like pneumonia. And then we're generating evidence. So this evidence that we're generating is currently missing and important. Maybe I should be taller. There you go. So we're generating important and currently missing evidence on the feasibility of using these tools, the cost effectiveness of using these tools, and the health impact of using these tools. And with that, we'll address evidence gaps to inform local implementation, local guidelines, and global guidelines. So hopefully the evidence that we're generating will be used to update all of these guidelines and to help countries implement. And lastly, through innovation, we're accelerating access to tools like clinical decision support algorithms that help healthcare workers make better decisions, and next generation pulse oximeters, like Elsa described, that can add features to a pulse oximeter, which normally measures blood oxygen and pulse rate. And these new devices can do things like automatically count respiratory rate, measure hemoglobin, and temperature, and other features. So the goal is to help healthcare workers detect severe illness in children and make that detection more robust. So by doing all of this, really the goal is to expand access and collect data that will not only benefit Kenya, but will also be beneficial globally. So that will generate global demand for these tools, will inform WHO guideline updates, will increase donor engagement, will provide incentives to manufacturers to innovate and create these tools that can be affordable, and will also guide other countries. So we're hoping that countries will follow Kenya's lead to implementing these tools. So despite the tremendous gains that we've made over the last many decades, child deaths are still unacceptably high. And as World Pneumonia Day approaches, pneumonia is still the leading infectious disease killer of children under 5. And so this is a stark reminder that we need to do more to help achieve the Sustainable Development Goals, and we need to work together. So I'm really grateful for all of you for coming today to this event. This is just a key milestone and a lot of work that's already been done by all of you, and a lot of work that remains to be done. And we're going to do it all together. And it's paramount that champions at all levels, local, global, regional, put integrated approaches to pneumonia and other diseases that are available, access, and affordable high on the agenda. So we keep talking about this. And lastly, Tmci is an opportunity for all of us to join together in action, evidence, and innovation, and to empower healthcare workers and caregivers and to equip implementers and decision makers so we can move forward. And is an opportunity to, again, together, scale up access to needed tools for accurate screening and diagnosis for children, and to accelerate progress towards health equity. And we can do that in Kenya, and we can do that globally. So thank you all for the time and the opportunity to speak. And with that, I will hand it back to Caroline. Okay. Thank you.
So thank you, Mike, for your remarks. And indeed, Kenya is a signatory to the Global Pneumonia Declaration. And last year, during the commemoration of the World Pneumonia Day, the Cabinet Secretary, represented by the CAS, Dr. Mwangangi, did sign the Pneumonia Declaration that commits Kenya to put in resources that will help and reduce preventable deaths due to pneumonia. So I'll invite from the University of Nairobi, Professor James Mashoki, to give us his brief remarks before Andolo gives us a brief presentation on Tmci and the ECDSA. Thank you. Welcome, Professor.
Thank you to all of you. Thank you, all distinguished guests who have been invited. Dr. Mulwa, Director, Preventive and Promotive Health Services. Dr. Bashir, and DFH. Caroline Juguna, East African Hub Director and the Path Country Director. Tmci Global Director, Mike Rufo, the county representatives here, distinguished guests, ladies and gentlemen, good morning. Good morning once again. As University of Nairobi, we feel greatly honored that we were given this opportunity to be part of this study, this project, because as a university, our expectation and what we are expecting to provide is the best evidence to improve health outcomes. When it comes to improvement of health outcomes for our children, then we feel good, we feel happy. We are therefore very appreciative of PATH to make us be part of this project, which we strongly believe is going to be a game changer in terms of how we improve the health outcomes of our children. Because unless our children grow well, are born well, are educated, without any diseases, without any morbidity, and obviously without any mortality, then we are a country that should be proud of itself, proud of its leadership, proud of its academic institutions like University of Nairobi, and proud of its politicians, of course, if I may say so. For us as College of Health Sciences, which is representing University of Nairobi in this project, we have a long history with the Minister of Health. I think and I feel, having been at the top leadership of the college for a while, for almost now this is my third year, and therefore part of the university management, our role and our key business being a university is how we work with key partners who are key in improving our health outcomes at all levels. Because health is central to all that we stand for as a country at all fronts, whether it's economics, whether it's politics, whether it's policy, and so on and so forth. And so our partnership with the Minister of Health, we consider is extremely very valuable. And whenever I'm requested to provide any one of my staff to be part of the technical teams, I'm always more than glad to do that. And particularly when also we know we have contributed the best leadership that is running health in this country. Mulwa was one of our shining stars across the board. I remember when he was in the medical school, he looked like a leader, and he has continued to be a leader. And we appreciate you for that. Once in a while, I was joking with him when I'm sitting with my children watching TV, and I have many, by the way. And I see him, I tell my kids, that's one of my kids. When they look at me, I say, it doesn't look like us. But I tell them, look at the nose, it is like the one of Stanley. So, so really, we are happy as a college. And part of my motivation to stick in the public service, the minister of so many other very appealing and appetizing options, is because that's where really you can make a difference in the public service. So my message to us, because I believe a lot of us here in the public service, in spite of the pain and disappointment and all that which comes with public service, including corruption and the overeating, and even sometimes puking on people's shoes because of overeating, have hope, have faith. I think we shall make it. Dr. Molo, I'm sure you agree with me. And Dr. Bashir, a lot of us who are still in the public service. And so really as a university, is to appreciate PATH as we know it, is to appreciate our partners in the counties. We're in those 3 counties, and at entry, we did tour the 3 of them, and we were so delighted to see how much we were appreciated. University of Nairobi, yes, welcome. I think wherever we go, we feel like we are doing well, and particularly the College of All Sciences. And so therefore, for me really, to lead this project at the University of Nairobi, the day will be most exciting to talk a lot and say a lot is the day when we will be producing that which we are known for, best evidence, to address that which we are all talking about today. That contribution we shall make is what makes us stick in the public service, in spite of all that which you know about being a public servant. The team with me, therefore, I can't really fail to recognize them because they have been phenomenal. They have really done great work so far, this far. Even in the midst of COVID, they risked their lives to go and introduce the project. And I'd like to recognize them, led by Francis. Please, can you stand up from University of Nairobi? Yes, all of you. And I think there is the youngest. Yeah, Rosie is there also. Nice to see. So this is the team. You can see we are fairly gender sensitive. These are great researchers. Yes, you can see. I think they deserve a clap. This is the team which is going to give us the evidence. Francis is the team lead, and Mercy, health economics, Maria, the qualitative, then of course, Gary, data, and then Rose Koskei is there, one of the clinicians. And so this is the team, please have a seat. Proud of them. We work as a team, and we want to build young ones, and we want to make sure we provide that which universities are known for. As we were chatting before we started this program, I was telling Caroline Jugona when we were asking who will save this country. And I said, yes, a savior shall come, but I believe it may not come from the universities, because even universities sometimes are not as clean as the rest of the population. So we may not blame one sector. But my point here is that as universities, we are expectant, so much is expected. And I always tell my colleagues, we must clean our houses first. If we can, also the rest of the country can clean our houses as we talk about it. And so therefore, our colleagues, ladies and gentlemen, our partners in this project, my commitment today as we start this journey, as we launch this project, is that University of Nairobi will not let you down. The team I've introduced you will not let you down. And I believe the day we'll be sharing the results and the findings, you'll clearly see that. And so therefore with that, once again, we appreciate PATH. This is the first project PATH is implementing with us, and we are looking forward to doing a lot more work because we know who PATH is, we know their global standing, we know their contribution locally and globally, and for how many years they have been on this in this agenda of health at all levels. And so therefore, for us to grow as a university, we would want to partner with research. In any case, that's part of our core mandate, to partner, to provide evidence, to improve health outcomes, to improve various environments of human endeavors. And so we are happy to be part of UPath, and of course, the Minister of Health and the county government.
the counties that we want to say the poverty index is still high. And then you link that to the childhood illnesses. There are a lot of childhood illnesses. We talk about things like diarrheal diseases, the pneumonia, which is one of the top 10 diseases in Kakamega. The project, we feel that it is actually like a game changer for us. And we think that where we are going, especially with the fact that Kenya now is adopting EMR. Many counties are beginning to adopt EMR. And now the Tmci project is also introducing it to the tablet world. It is marrying in that we are getting to the digital space, getting out of the burden of having documents which people have to write down. Now, when the national governments devolved health services, I think counties which are here, you'll recognize that one of the challenges is printing the tools, the mother-child booklet, and all the other MOH7 or something, those tools, the 105, 710, and all that. So when we have a digital process, it helps us to relieve them of that. And then, of course, when we are talking about the COVID world, COVID world, when you have these documents which have to be transmitted from the dispensary to the health center, and then now being summarized at the district headquarters, and then at the sub-county headquarters being taken to the county. Of course, you want to cut off that transmission. So we want to really appreciate for that. And we think that as a county, we are proud to be part of this project, because when, especially when you talk about the pulse oximeters, they've been a real blessing for us. We got a donation of pulse oximeters from PAP. And I think that one has really helped us, especially to take care of the health of young children. When a child comes, especially in this COVID space, and they have a respiratory problem, and there is no pulse oximeter, sometimes as a clinician, you become a little bit, you find it a little bit difficult. You want to, is it pneumonia? Is it COVID? And all that. But with the pulse oximeters, I think it makes it easier. And we want to thank PATH for that. For the University of Nairobi, that is where I studied. And I think I'm happy to see Professor Imunya is still. Only that time you are a little bit slim. I think right now you've grown bigger. I think I almost failed to recognize you. That I graduated in 2001. 2001 is some years back. Yes. So thank you very much. University of Nairobi, we are happy to be associated with you. We know that in terms of now research, many counties, because we are still young, when we get inculcated into research, and then we start doing our own research in the counties, it will become very good, because now we'll be helping to solve our own health problems. I think I want to appreciate the association we have with the University of Nairobi and the PAP. And for all the other guests, I think, thank you for coming, and we are happy to be in Nairobi. Thank you.
Thank you, Dr. John, for coming to speak on behalf of the counties. I'd now like go straight to Tmci project lead presentation. He'll give a brief presentation before I invite the head of department, Dr. Isaac Bashir, to make his remarks. So Mr. Andolo Miheso, who is an alumni of the Division of Neonatal and Child Health. Welcome. Yes, thank you.
Good morning, ladies and gentlemen, and thank you so much for honoring this particular occasion in your aspirations to be able to contribute to child survival, growth, and development for Kenyan children. Before I make a presentation, I just want to introduce the team that are making this presentation on behalf. Please, the Tmci team, can you stand up? So the Tmci team, we have Janet Shauri, who is the program officer for the project. We have Dickens, who is the monitoring evaluation and sometimes referred to as also learning, who is part of the project. We have Catriona Mumuli, who is part of the project to be able to advance the aspect of advocacy and communication. And already she's working with the counties to mainstream Tmci project in the budgeting aspect. We have Pauline Irungu, who is a lead for public a program for public policy at PAD, to be able to see also that what Tmci project will be working on will eventually find its way in being mainstreamed in policy documents. We have George Nyamao. George Nyamao is a finance administrator who we ask, can we do this function? Are the resources there? Then we have honored also to have Mike Rufo, who is the global director and who gives guidance. And as I mentioned also, we're also working with the University of Nairobi very closely, and they are able to be introduced. But we're also working very closely on the project with the team from the Ministry of Health. So thank you for the contribution. My name is, as it was mentioned, Amandolo Mheso. I work with PAC on the Tmci project as the project lead for Kenya. A lot has been said, but I just want to go through brief slides to highlight why we are here and why we need to move to the next phase. So globally, we know many children are dying of preventable illnesses. Close to about 5.2 million die each year globally, and they die from preventable causes. And every year, caregivers seek, care in the health facility. And when they do, they require the best. And that honor is on us to be able to see what we can do. Often they require correct diagnosis and treatment, which is important to ensure that their children will recover. And also unnecessary death will be prevented. From the pie chart, it's known that neonatal causes, and particularly pneumonia and diarrhea, are the leading causes globally. In Kenya here, we know that pneumonia contributes to about 80% of the under 5 deaths, but the leading cause are the neonatal causes, which contribute to about 39% of the death in children. We also know that from KDHS 2014, as a country, we're making progress towards reducing childhood mortality, which now stands at about, for the under 5, which stands about 52 per 1,000 live births, and 39 for the infants, and 22 per 1,000 live births for the neonates. We also know that the neonatal death has been reducing at a very slow rate and almost constitutes to about 60% of the under 5 death in totality. We need to do something to protect these children from dying. We also have a sustainable development goals, where by 2030, we need to reduce this 52 per 1,000 live births for the under 5 to about 22, and the neonatal death, which is 22 per 1,000 live births, to about 12 per 100,000. That means we need to have what we have today here, innovate, to see what we can do to bring this death lower. The goal of the project has already been mentioned, but just to reiterate, is to make a diagnosis of very severe disease using pulse oximetry and clinical decision support algorithm. And we will explain, I'll explain a little, how would that do to achieve this particular goal. And again, to contribute to acceleration of non-invasive tools that add additional features to a standard pulse oximeter. Most of you who are here and have worked in the clinical setup, often you get frustration. You have a thermometer somewhere, you have a respiratory counter somewhere, and you need these things. So often you measure one thing and you're unable to do the other. If there is an opportunity to have all these things being done by one gadget, which is non-invasive and which provides consistent measures over time, that is something we should work together to provide. And this is part of what Tmci project will endeavor to achieve. As we mentioned, this is a global project in many countries. It has many partners, particularly at the highest level of learning and institutions in the countries in which Tmci project is being implemented. And the map here represents those countries, and you can see they are from diverse global perspectives. Now, why are we here? Why are we advocating for new tools? Basically, to answer the question, tools already exist, but they can be used in a better way than what we are currently doing. There is low adherence to guidelines. Danger signs and measurements are infrequently assessed in sick children. Many of you who collect, information from facilities, sometimes you find what you want to collect is not available because it was not entered into a register. You have to find alternative means of how you can collect it. Also, infrequently, when you look at those registers, you find classifications or diagnoses are not there, but treatment is there. Treatment for what diagnosis? Treatment for what classification? And many a times, children who would have had a severe illness are not referred, basically because health workers didn't find it necessary, or they didn't identify it because they used clinical science that sometimes are subjective. What you think is severe to me may not be severe, but ultimately that child may be having a severe illness. There are reasons to explain this. There's some knowledge, gaps, resource constraints, health workers are overloaded with work. And again, we also know that not much advice may be given, particularly when children present with fever. Majority may end up having treatment with antibiotics, which may not be appropriate. It's also challenging to some health workers at times to be able to integrate different diagnosis and treatment. And therefore, we are arguing as a Tmci project, we are arguing from a perspective of how do we facilitate these health workers, particularly the lower levels of level 2, level 3, to be able to integrate and make the right diagnosis, the right treatment, and the right decisions. These are some of the guidelines that already exist. And I think in some forums, Kenya, we are known for being a country that is very, agile in producing guidelines. We have Tmci guidelines. We have kangaroo mother care guidelines. We have essential newborn care guidelines. We have newborn, care handbook, comprehensive newborn care. We have integrated management of childhood illness guidelines. But as I mentioned earlier on, oftentimes health workers don't do these guidelines as is expected of them. We have hospital care book for children. We have the basic pediatric protocols to be able to facilitate better decisions. But at times, health workers don't use them. So the issue here is how do we encourage health workers then to use these guidelines that already exist? Tools for integrated management of childhood illness is proposing a way we can be able to consistently ensure health workers are using and making reference to available guidelines. Now, so children with severe diseases not identified by clinical signs alone, again, clinical illnesses may not be identified by signs alone. We need to provide additional gadgets like a pulse oximeter, standard pulse oximeter, and referencing what Dr. Otieno said, once SpO2 levels are less than 90%, irrespective of eventual diagnosis, that is be enough to merit a referral. And also using clinical guidelines to ensure that they are consistently used. And therefore, the clinical decision support algorithm will consistently and guide a health worker, depending on the input of information, to make the right decisions. I just want to talk about the activities which the Tmci project is involved in. First is introduction of pulse oximetry and clinical decision support algorithm. For the 60 health facilities that are referred to, we're going to provide every facility with a pulse oximeter, as well as various national guidelines that are used for child health, digitalized in CDSA for the health workers to use. Then there is impact evaluation and cost effectiveness and operational research, which will inform how the future guidelines are structured. At the University of Nairobi here will make a presentation on how this impact evaluation, cost effectiveness, and operational research will be carried, and what key indicators they'll be looking into to eventually inform guidelines decision. And this is very important because that is information which will lead into how do we scale within the counties where we are already, how do we scale regionally, and how do we scale the project globally. The other major output is advancing next generation of pulse oximetry and multimodal devices, which I've already alluded to, and eventually utilizing the evidence we generate to be able to inform policy, resource mobilization, and procurement of essential medicines. Now, I just want to go through how the stakeholders were involved in deciding to use pulse oximetry, as well as the clinical decision support algorithm. So the intervention is we provide these two gadgets at level 2 and level 3 facilities in the 3 counties, which were chosen by the involvement of the counties themselves and the team from the Ministry of Health and the team from PATH, and as well as the team from the University of Nairobi. To be able to provide these 2 interventions, there'll be need to support health workers in training, which will involve training in the core area of child health, which is IMNCI guidelines, pulse oximetry, CDSA, and record keeping. Support supervision will be crucial. Supply of essential medicines is also crucial. And monitoring and evaluation would be things we shall also undertake to ensure that the introduction of pulse oximetry and clinical decision support algorithm is taking root, and we are generating evidence. As alluded to earlier on, we know care seeking in Kenya for the children under 5 is not optimal. For example, children who have pneumonia is only 66% who go to health facilities. What happens to the rest who constitute almost a half, the 34%? Those needs to be sensitized by their caregivers to see the need to seek health care and also to take up follow-up. In many of our facilities, we know ordinary follow-up, come after 2 days, come after 3 days, is not often taken up. So that is why in Tmci project, the country director alluded to, there being at least a civil society organization in each county to be able to stimulate interest and uptake of child health services, and also to encourage so that numbers are available to the University of Nairobi to be able to do the necessary research Now, why did we choose on pulse oximeters? They are non-invasive, easy to use. They're accurate also to detect hypoxemia, almost at the same level if you're using oxygen arterial circulation gas analysis. In primary healthcare, they can also identify children who require immediate referral and can also encourage caregivers to take up referral. This was also, we also chosen as a country to use pulse oximetry on all children who come to a facility, not using those we suspect to have a severe illness. And also to use pulse oximetry on children who come for a follow-up, just in case a severe classification was missed during the initial consultation. This decision was arrived by the stakeholders who participated in making these guidelines. They thought it aligned very well with the tool Dr. Caroline mentioned, the registers, the existing COVID guidelines, and as well as data collection and reporting tools. It was also simple, and it also mainstreams into every other symptom. So irrespective of whether the child has pneumonia, has a cough, has diarrhea, has a fever, there will be still value that you will generate by using pulse oximeter in that particular child. Other countries, as we say, it's a global project. They have chosen to, first of all, assess a child. When the child is severe, is when they will now use a pulse oximeter. Or if a child has a non-severe classification, is when they use a pulse oximeter to see if signs have missed something that is clear. But for us as a country, for every child, during the first visit and on referral, we give opportunity for severe illness to be identified. Now, just about CDSA in this slide, I just want now to summarize. It will guide health workers step by step. You say this child has a cough, please assess for respiratory care. You say this child has diarrhea, please assess for the level of dehydration. And that way, things that are often missed, a health worker is compelled to be able to do them, and thus providing quality assessment, the opportunity to identify a severe illness. Now, I just want to go through this slide to say in now taking the available guidelines into CDSA, there was a process which began by drafting the conditions which consisted of the University of Nairobi, Perth, and Swiss TPH. Swiss TPH is our collaborating institute, which is a Swiss Tropical Public Health Institute. Then we went to the next process, which was a validation through the Ministry of Health, technical working group, and a panel of experts looking at what the suggestions are and how they relate to the current guidelines. And eventually we had field testing, and we are currently doing a pilot in 5 facilities. The pilot facilities are represented here. They'll have an opportunity to share with us what so far their feel is as they use the tool. But as we launch, as we ask you, the chief guest, to launch this for us, we will continue using it in the field. And in the last, in the research pilot part of the slides, then at the University of Nairobi, then we'll do mixed method pilot, research studies to evaluate uptake, usability, acceptance, workflow, and others issues in the facility. Now, it was mentioned our project sites, which are here, but I just want to say in choosing also the counties, it was a consultative process where stakeholders came together and said, fine, let's have one in Western region, which has a different mortality rates and attitude. So Kitui, Western Gishu, and Kakamega, one then considered. And in this slide, I just also want to reflect the partnership that exists in implementing this project. I just want to say when this project came into being, which was 2019, COVID also came around. And the COVID also slowed down the project implementation. But the project didn't sit it met a key vote to support the Ministry of Health response to COVID-19. What we did, the country director was able to mention some of the achievements we did as a project. We'll continue to explore possibilities where we can support ministries when need arise. But I just want to show some of the pictorial events when the project was supporting COVID-19 efforts. So in the first slide, that is the committee executive members of Wasingishu County. So in the first slide, that is the in her county where she was. When we did the donation, she said no. And there were others tested on me first. Then someone said, what if you have a low SpO2 level? He said, no, that will not be a problem. In the next picture is His Excellency, the Governor of Kakamega County, when we also donated a pulse oximeter. And looking on is a former country director. And then Rose Muhando is represented here as one of the persons who are present. In this slide, we project also as a consultative process is in Kitui County. And on the seat of power, as you can see, the far end is the County Executive Committee member for health for Kitui County, contributing ideas. And in there are also the partnership that is in this project. In the next slide is a part of the training which the project supported in terms of COVID-19 response. As I mentioned, we also made a pivot to assess respiratory care equipment in Tmci projects and be able to rehabilitate those that are rehabilitable to ensure there is access to medical oxygen. So before you can see some items looking in bad shape, isn't it? So these were the concentrators, and thereafter, through one of the farms, we are able to hire medical. They have now been rehabilitated. We've done this in the 6 counties where we found respiratory care equipment that needed repair. We've done the repair. Additionally, we've also trained the biomedical engineers in those counties to take over the maintenance thereafter. The next few slides is I want to do a demonstration. What is it that CDSA is bringing about, which is different from what we are doing? Dickens, I'll change my position so that I can be able to talk on this side. Yes, Dickens, please, next slide. So the menu of CDSA. CDSA will have different menus. I'm using this menu. The first will be, yes, Dickens, please. Yeah. So there is this first screen where there is a registration. So during the registration of a client, the health worker will ask a number of questions. There are some questions that are mandatory. The health worker has to fill them before he can proceed. If he doesn't, the tool will not allow him to proceed. But where there are some that are optional, and sometimes within reasons within an institution, there may be reason not to be able to do that. The tool will allow a health worker to move to the next. So here the tool will be comprehensive enough to capture the information. And that will be the first screen. And take it next screen. So the next screen is before the health worker progresses. The tool asks if the child has any emergency problem. And once a health provider identifies that the child has an emergency, he clicks on that particular emergency, and the tool will give the options on how to handle that particular emergency. So a health worker is not being left, in ignorance. Okay? He is being provided with options of if this child is convulsing now, if this child has difficulty in breathing, this is how to do it. And additional information is provided. I think it's next. Now, once there is no emergency, or if there is an emergency, child health provider handles the emergency. But where there is no emergency, the health worker moves now to the complaint category. In this complaint category, are structured at the level where health worker is given the options of what is possible, so that at once he picks the likely conditions. And these are conditions the health worker is going to ask. So if they are not there, if they are there, the health worker will say yes. For the purpose of this demonstration, I have chosen to say the child has a cough. The therefore that will appear yes, but where these other conditions are not, they will appear as no. But if they were present, the moment a health worker takes yes, 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 the next subsequent screen will provide mandatory feed the health worker should assess for the particular complaint the caregiver has provided. Yes, the next one now are mandatory measurements. Things like, child's weight, child's length, child's, child's, temperature, and child's SpO2 level are all mandatory. And if a provider doesn't provide a reading for any of them, the tool doesn't proceed. It will remind you, please take temperature, please take SpO2 level, please take weight, please take, length. Because these are also key parameters that are used in decision making. Next. In this slide, now, in this slide, there is what we call data science. And in this country, we have a Kenya Service Provision Assessment, which show that healthcare providers are only able to assess for data science in about 13% of the consultation. So this will pop up to ensure that for every child, he is mandated to assess for gender data science. It is present, if it is not. Therefore, ensuring that quality care information will be available for decision making. Next next. Yeah. So after next, there is the general examination that will be after he has asked for the presence of general examination. He needs to do a general examination, be able to establish the presence for their absence. But because the health worker chose in this example, the child had a respiratory illness, which was hope will come up, respiratory program will come up, saying the child health worker need to assess for signs related to a cough. Usually straight and unharmed child, chest and the rest. So in this case, I've decided to say this child doesn't have, stridor. This child has a chest injury. This child is not wheezing. But you can see here, because I have not answered what I've not. If you don't answer anything, the right thing will pop up. So the health worker is forced or reminded to be able to. Next, next. Okay. So after the health worker has answered and assessed everything, there is the tool will suggest tests based on the information health workers have provided. But it will also allow this health worker, without removing the autonomy of the health worker, to be be able to do additional tests if the health worker thinks they are necessary. But the first test that the tool will provide will be on the basis of the information the health worker has set. Next ticket. Then it will propose the diagnosis for the health worker. And the health worker is still given the autonomy to agree or disagree. But as it proposes, it provides additional there's an information. So before the health worker disagrees or agrees, where the health worker wants to disagree, the tool provides information. If he clicks on it, it will say, for example, if a child has pneumonia, these are the possible signs. If you see this in this particular child. Therefore, whenever a health worker disagrees, he will disagree and he will be sure that his disagreement is because what the tool suggests was not found in that particular child. So in this case that we used, it has proposed pneumonia, moderate malnutrition, and then we need to screen for development. Next. So finally, next day it will propose the treatment based on the classification that the health worker has provided. And this treatment, the health worker has also to agree whether those would be the treatment that this child will be provided. Next. Then, so for each of those, it will provide the required treatment. So for example, for pneumonia, it has proposed because this child had fever, the child will need paracetamol. Because this child has pneumonia, the child needs some oxygen dispersible tablets. The next screen will go into the formulations that are usually available in the health facilities. So move on. Move on and details. And then, so this will be the formulations. Sometimes they are tablets, sometimes they are serums, sometimes they are suspensions. And the health worker will decide which one is present at that particular facility. Tickers next. Next, the tickets next. Next. Now, at the end of it, it will conclude the consultation and provide a summary. And that summary will include the decisions the health worker made, the treatment the health worker made, the advice the health worker obtained. And anytime now this child comes back, the health worker can click on the name of that particular child and be able during follow-up to see what was present during the first consultation and what is now present in the second consultation. So finally, ladies and gentlemen, I just want to say this tool will provide opportunities to health workers to minimize missed opportunities, to identify the very sick children, to institute appropriate treatment measures. Now, our next step after this, after you launch this project for us, the chief guests, will introduce pulse oximeters and clinical decision support algorithm in the rest of the 60% facilities. Beginning with the process of training, which will be a collaborative effort between Ministry of Health, the University of Nairobi, and the county to prepare health workers on how to use pulse oximetry, CDSA, and to also refresh them on integrated management of childhood illness. We will also now, through the University of Nairobi, create, data for cost effectiveness and the best practices in the facility. We'll also continue to strengthen evidence for global utilization. So, ladies and gentlemen, that is what the project is about. It is an effort to innovate, to contribute to better childhood illnesses management. Thank you.
Thank you, Andolo, for that comprehensive introduction and explanation and demonstration. I think we're now all on the same page. We know the importance, we know the burden of pneumonia in our country and indeed globally. We know where the gaps are, especially in our health systems, and the proposed solutions and innovations. But at the heart of all this is the healthcare worker, who we must support to use these tools to make the best decision to save this life of the child and offer the best care that is of quality. So, ladies and gentlemen, allow me to make a slight change on our schedule. Our chief guests have a busy schedule, so we'll allow them to proceed with the part of remarks from our head of department, Dr. Isaac Bashir, who has greatly supported the Division of Neonatal and Child Health. Welcome, Daktari, so that he can make some brief remarks, and welcome, Dr. Mulwa. Thank you.
Thank you, Dr. Carol. Allow me to recognize our Acting Director, Preventive and Promotive Health Services, Dr. Mulwa, who is the chief guest. Dr. Caroline Mwangi, the head of Division of Neonatal and Child Health. Our colleagues from the 3 counties, Kakamega, Uasin Gishu, and Kitui. Our partners from PATH, led by Caroline Jibuna, who is the country director and also East Africa Hub director, together with Tmci Global project director, Mike Rufo, and not to forget our teacher, Professor James Machoki, and his team from the University of Nairobi. Colleagues, it's an honor and also pleasure at the same time to be participating in this meeting and seeing this innovative and life-changing, impactful project launch. I say this because one person's idea, if he's able to sell it to the others, can move mountains. And I believe in this space of child health, it's very difficult to explain why Kenya today is struggling with basic diseases like pneumonia and diarrhea. Because I believe as a country, we have what it takes to, if not eradicate, to limit the damage and the deaths these diseases are causing. Mine is to share with you our experiences, and the most important component of this project, I think, that is the partnership that you develop. The experience I gained out of being in this space of program management for the last 20 years, the biggest ingredient is having a partnership that has gelled well. Because everybody, therefore, will bring unreservedly onto the table the best that they can do and they, in their own expertise. It's unfortunate that the academic institutions and the ministries, whichever area you are in this particular moment, Minister of Health, should be inseparable Siamese twins, because the ministry does policies, does policy directions for our country. And this policy direction is supposed to be generated by the academics. We've always been relying on evidence generated in the country, but by outsiders. That should not be the case. I think we have what it takes, and this project, we are looking at it. What is the power of the study? what is the quality of evidence that we're going to generate from this, so that henceforth we build our own capacity and don't rely on evidence generation from outside this country. I know USAID has taken some steps in building capacity of the local organizations and institutions to do what it takes for us to generate our own information and our own policies. Therefore, I also want to appreciate our partners, PAL, as both for the resources, whether it's technical resources or financial. It takes quite an effort to mobilize resources for any project. But this one, I believe, is very sellable. And we're starting with 3 counties so that we can generate enough evidence for even the country to scale it up. That's my take. It's not a pilot to die, but it's a pilot to be scaled up. Once you know something is working, we have to go back to our own coffers at county level. And I'm looking at the 3 pilot counties. You are lucky to be the first 3 counties, but it is also your responsibility to ensure that not only 20 facilities, but within your counties, all your facilities scale up this project before the end of this support from PAL. And also at the same time, advocate for the same to your counterparts in the other 44 counties. That's the way we can take it up as a country. At national level, we will do what is required for us to sell it once we have the right evidence. But you know, health is devolved and the implementation happens at the county. So the ownership really, ours is for guidance and policy direction, but the ownership of implementing and owning it up is at the county level. Having said that, I wish to enumerate a few of the contributions from our team in the Division of Neonatal and Child Health so far in this project. And they were part and parcel of the initial consultation, and that's where we got it right. If there's no consultation at the beginning and you don't know which direction and what challenges the ministry is facing in dealing with this any agenda, then you cannot come and sell that project, however good it is, because you have missed the first step. So I want to assure you that my team has confirmed that they were part of the initial consultation, and this was a very consultative process, and that is the beginning of building of partnership. The department, through the division, has supported county introductions of Tmci, country introductions of the 3 counties in August 2020. The same division constituted a country implementation working group at both levels of governance, national and county, participated in the rapid assessment of facilities for the focus counties and selection of facilities for project implementation, developed and reviewed training materials incorporating the use of pulse oximeter into the IMNCI 2018 guidelines in October 2020, identified and trained TOTs in February 2021, participated in the development of electronic clinical decision support algorithm in August 2021, participated in the pre-testing of the same, and trained health workers from the selected facilities in the tools in August 2021. This shows that we've been working together, and the government provides not only policy direction, but the space for all these partners to be brought together and to gel. You can go to County X and County Y, but bringing all these counties together under the leadership of the ministry is something that is invaluable. And therefore, mine is to guide you, and mine is to really encourage you to continue the same. We're here, and my director is here. Whatever is possible for this project to work, we have the mandate, we have the powers, and we have the ability to make it work. And therefore, ours is to confirm our commitment and our support for this project. Without taking time, I want now to welcome Dr. Mulwa, our director, to give his speech and also launch the project. Karibu Daktari.
Thank you very much, Dr. Bashir. To the head of family health in the Ministry of Health, Dr. Bashir, Dr. Caroline Mwangi, the head of child health in the Ministry of Health. I must start by saying Dr. Caroline Mwangi has amazed me that she is doing her second week as the head of, first week rather, actually, as the head of the division, and one will not realize that she's new in that as the head of. We need to start by congratulating her and applauding her for a job well done in your first week. Even the speed that you move at Daktari, I can assure you, the sky can never be the limit. Our partners, Path, led by Caroline Juguna, and Global Tmci, Mike Rufo, our teacher, Professor Machoki, and the whole team from the University of Nairobi. I must appreciate, Prof, your high praise. It is on very rare circumstances that teachers praise their students, and I don't take that for granted, but I will keep keeping on so that I don't embarrass you and the university for the good work that you've done so far in making us what we are. The county government of Kakamega, led by the director, was in Gishu and Kitui, and our partners, ladies and gentlemen, including the Fourth Estate. Good morning. Good morning. Before I joined the ministry some 5 months ago, I had a very easy time because I never used to have talking notes whenever I was invited to address functions like this. As the chair of CECs, I would just have my points on the fingertips, then come and speak them out. But I've learned in the ministry is a protocol to have your talking notes. I am still struggling with that, but I hope with time I'll be able to learn and make speeches out of written notes. I must start by thanking our partners, Path especially, for organizing this. It is commendable that you have chosen to invest in child health in this republic. I still remember my days in the clinical work and how pneumonia used to be a serious, a killer disease. It still is a killer disease, despite the improvements that we have done, introduction of a pneumococcal vaccine, and now moving to now what I would call a quality of care. Because what I have seen in the presentation that has been done by Andolo is actually a system that guarantees quality of care for every child that goes into a health facility in these 60 facilities. That is what I would say I have picked, that what we are doing is using digital platform to guarantee quality of care for every child who presents in a facility with pneumonia. I want to thank the University of Nairobi for working with the Ministry of Health, because like Dr. Bashir has already alluded, and Dr. Caroline Mwangi as well, that our role as the Ministry of Health is to provide standards, guidelines, and policies. And this can only be backed by evidence, so that we develop policies and guidelines that are based on evidence. On behalf of the Ministry of Health, I'll make now the official remarks. Kenya's under-5 mortality remains a key issue of public health concern, and currently stands at 52 per 1,000 live births. The leading cause of under-5 mortalities are pneumonia, malaria, diarrhea, and neonatal causes.
Neonatal mortality alone accounts for 45% of overall under 5 mortalities and 59% of infant mortality. The main causes of neonatal death are asphyxia, prematurity or low birth weight, and sepsis. In most of these conditions, oxygen saturation levels in children is compromised, and hence the need to monitor the same to inform decision in diagnosis and management. Pneumonia remains the one of the top 2 killers of children under 5 in Kenya, accounting for 1 out of every 3 deaths. 15% of child deaths were due to pneumonia in 2018, and it was the second biggest killer of children under 5 in 2017. Pneumonia indeed killed 9,000 children under 5 in 2018, more than 1 child every hour. Hypoxemia, which is low oxygen in blood, a condition which is common in severe pneumonia, contributes to 800,000 deaths in children worldwide. Pulse oximetry is recommended by WHO in assessment of sick children and has been adopted in Kenya's integrated management of newborn and childhood illnesses, as had been demonstrated by Andolo here. We are happy to know that the tools for integrated management of childhood illnesses brings with it a step-by-step approach on how children with severe illnesses will be managed. I think Caroline Muduguna already took us through the Tmci, which is a 4-year global project led by PATH in partnership with the Ministry of Health, the Swiss TPH, and the University of Nairobi with the support of UNITAID. The two major goals of this is to improve detection of severe disease in children under 5 years of age, including young infants, by 1, improving primary healthcare workers' ability to diagnose severe disease by equipping them with pulse oximeters and decision support tools. 2, to accelerate development and market entry of non-invasive devices that augment the features of standard pulse oximetry, that is, have the pulse rate and respiratory rate. The project is being implemented, like has already been said, in 4 focus countries: Kenya, Senegal, Tanzania, and India, in the Uttar Pradesh state. In Kenya, 3 counties, that is Kitui, Uasin Gishu, and Kakamega, have been selected for introduction of pulse oximetry and the electronic clinical decision support algorithms. In each of these 20 facilities, this has already been mentioned, and that's a problem of being the last person to speak. You most of the times repeat what has already been said. In each of the 20 of these 20 counties, 20 facilities have been chosen, bringing it to a total of 60 primary healthcare facilities, of which 17 have randomly been selected for research activities. The goal of the research component is to generate evidence on the operational fit and cost effectiveness of introducing pulse oximetry and electronic clinical decision support algorithms in primary care in low and middle-income countries to facilitate national and international decision-making scale-up. Therefore, as I conclude, I think is to reiterate what Dr. Bashir has already said, that yes, we are doing this in 3 counties. And sometimes they say Africa suffers from a disease called palatinitis, and I want to believe we are not just doing a pilot. What we are doing is we are doing proof of concept, and with intention to scale up with the 47 counties. So therefore, the county directors who are here, county management teams that are represented here, you will be our team leaders in terms of building the capacity of the rest of the 44 counties to ensure that in 1-2 years that we scale up this to the rest of the country. Our colleagues from the digital health platform led by Dr. Sitine may not be here, but my presence represents them, that as a ministry, we are, and the cabinet secretary in particular, is very committed to ensure that health delivery in this country adopts to digital platforms. In fact, according to the cabinet secretary, the clinician of today will be irrelevant by 2030 if we don't adopt digital technology. And this is one way. When I was practicing, we used to carry the pediatric protocols, all those in our pockets, and you would refer them. These are now digital platform that is moving us from that to, and I think it's scalable, and the ministry is committed to ensure that working with the counties, we mobilize the resources so that we transition to full EMR in the shortest time possible. And this is one of the ways of doing so. I guarantee, and I already am getting the feel that with this, we will see improved outcomes. But that is work cut out for Professor Machoki and the University of Nairobi to tell us whether indeed there is evidence that this will lead to improved outcomes and improved quality of care to our clients. With those many remarks, I want to thank you, all of you. I missed the days that I was in the counties. I must say that those of you who are from the counties, you will have safe stay in Nairobi and travel back if you are traveling today. Myself and Dr. Bashir are pressed of time because we are already have so many other engagements that are waiting us, but it's always a pleasure to work with you. Professor Machoki, thank you for the good work that you are doing, and thank you for the collaboration and partnership. Path, we want to continue working with you. We'll work with you. We will be available on short notice to further this partnership, as Dr. Bashir mentioned. Asanteni sana.
Thank you so much, our guest of honor for the day. And at this juncture, I would request that you, Dr. Bashir, Caroline Juguna, Mike Rufo, the representatives from the counties, move to the podium over there so that we can have the official launch of the tools. So Kitui Kakamega, County Director of Health, Uasin Gishu, select a representative. Professor Machoki joined them, it's a PI, very important in this exercise. Yeah, so what will, so if you have okay. I'm the counter. So at this juncture, come here. Okay. So we will go 5, 4, 3, 2, 1, 0. So begin with me. 5, 4, 3, 2, 1, 0. Go. There we are. Tmci officially launched in Kenya today. our health workers shall be able to assess children in a more quality of care way. Thank you. Thank you, Pat. Thank you, Minister of Health. Thank you, counties. Thank you, everybody, for gracing this occasion. Thank you so much. Thank you so much. Thank you. Thank you. Hello, we still are on breakfast, eh? Sasa. So breakfast is still going on. Have a second helping, third helping. Our program still continues. And I just want to remind all of us that we are live, Facebook Live, YouTube Live. So go to all those live digital platforms and share. So at this juncture, we are still continuing with where we left. I want to invite the UON Tmci project representative, Mr. Francis Njiri, to take us through the next step. Welcome, my brother. So we are giving our colleagues who are serving a minute or less, a minute to serve so that we are quiet and continue with the program. Thank you.
Okay, good morning, ladies and gentlemen. Good morning.
Good morning.
Yeah, I get to speak after the guest of honor. So my name is Francis Njiri, and I'm from the University of Nairobi. I am doing this presentation on behalf of my colleagues who were introduced earlier. And the purpose of my presentation, scientists are known for making life look very complicated. I'm going to do my best to try and make it as straightforward as possible. So as you may have heard, we are working very closely with PATH, and our role as the University of Nairobi is evidence generation. So those two interventions that you have heard and all mentioned here, we want to see if they actually work. So I'm going to give you a bit of a background, a rationale for these interventions, the methodology that we are using to do this work, and where we are at this point. We all know that this is premised on the truth that we all know that many children, at least over 5 million, are dying every year because of preventable and treatable causes. Many of these common issues that we see in these children are pneumonia, diarrhea, malaria, which remain a very big problem. And hypoxemia is very common and a life-threatening condition in these conditions. So we know that many children are still being admitted in our hospitals with hypoxemia, and therefore identifying risk factors for this and finding how to improve diagnosis is therefore a critical step in identifying, in guiding clinical decisions. So the Tmci project is aimed at contributing to the global effort of accelerating the availability, adoption, and scale up of interventions that can help to identify severe illnesses in children, particularly those that are under 5 years. And this project has received funding from UNITAID and to PATH, and who have also partnered with the University of Nairobi to generate evidence. And therefore, the goal is to improve the detection and management of severe illnesses in children under 5, and improve the rational use of resources such as medicines and the referral processes by equipping primary healthcare workers with pulse oximetry and electronic decision support algorithms. As you will have seen before from Andolo's presentation, you can see there are 4 outputs in this Tmci project broadly. There is the introduction of these 2 equipment or interventions for that matter. There is the second output, which is evidence generation. And that is where University of Nairobi is playing a key role. Then there is the other part that will come, the market strengthening on the adaptation of these multimodal devices, and thereafter creating conditions for scale up. And I must mention that the last two outputs are really significantly dependent on output two. I will not dwell on this slide because we all know that this is being done in Uasin Gishu, Kakamega, and Kitui, and it's good to see our colleagues. I just came back from Kakamega and Uasin Gishu on Sunday, and it's good to see our colleagues here. And we all know the circumstances under which these primary health care facilities operate. They are understaffed. They may not even have good access to electricity and stuff like that. And therefore, it is important for us to see whether it's actually feasible to implement these interventions in those facilities. And if it is feasible, what needs to be done and at what cost? I'll not dwell on this one. This is, we already introduced the team led by a good professor, Professor James Machoki Soimunya. We have several leads, and we also have another team that is helping us in the office. The objective, the primary objective therefore of this study is to evaluate the health impact on the health and the quality of care outcomes of sick children who are below 5 years of age by introducing those two interventions, the pulse oximetry and the CDSA. And I like to refer to CDSA as electronic IMCI, because it's really IMCI in electronic format. The secondary objectives are to assess the prevalence of these severe illnesses or rather hypoxemia among sick children who are coming to those facilities, and understand the association of these, the different degrees of hypoxemia with the outcomes that we see according to how they present and the socio-demographic characteristics which they have. So we also want to evaluate the characteristics of the children, because the things we are introducing really are being used in children, but these children are being brought to the hospital by caregivers. They are being seen by healthcare providers in an environment of a hospital. So for them to be successful, we need to understand all those key players. The other secondary objective is to understand what are the facilities and what are the barriers to uptake. We may, sitting here at Pan-Afric in Nairobi, think that these items are really great and they can be beneficial to the people on the ground, but without understanding what would prevent these things from being, and therefore, healthcare providers, the community takes it, and they are so forth. You know, one of the in the counties, if you introduced a pulse oximeter you may actually in the care seeking behavior in the on what they perceive the pulse oximeter does to them. If, for instance, you increase the referrals, they may start saying, you know, if you go to that hospital, you'll actually be referred. Your children will not be treated. You'll be told to go to another hospital. Conversely, you may introduce that and they start saying, oh, you know, once you go to that hospital, you do not need to keep going to the hospital because the way you will be managed will be final. And therefore, increase even uptake of care seeking. So we want to see all those things. And that's why we have this team here. So we also want to understand how these interventions affect the patient flow. If you go to a dispensary or a health center, you will see the normal flow of activities. There are children queuing at every point, and adults queuing at every point. And once you introduce something like this, how does it affect? For instance, the IMCI guidelines. Many of these healthcare workers, and some of them are seated in this room, have memorized it. And therefore, they skip from step 1 to step 18 within a flash of a second. But now the CDSA will not allow you to do that. You'll have to go step by step. That means more time, probably. That means you never know what the perceptions of the healthcare provider will be. So we want to understand that. And if this is shown to work, for them to be part of the dream. The other secondary objectives are to look at the cost and the cost estimates. These things cost money, and we want to see what are the additional costs that are associated with introducing them. But most importantly, number 6 is to see the cost benefit that is associated with introducing them, because it just doesn't cost money. It's supposed to save lives, supposed to improve the quality of care. And we have Dr. Mugo there who is able to put those numbers together and tell us how many infant mortalities have we averted, how many sick children would we have had if we didn't have all these things at the cost that we incurred. And we are great to have that. So without going into very complicated scientific details, this is a mixed method study. We have the longitudinal study, which is running for 15 months, starting with 3 months of baseline and 12 months of intervention. And before we actually introduce the intervention, we'll be doing some piloting to ensure that by the time we are introducing it, we have a sense of what we are likely to face on the ground. We have the service provision assessment. So we'll have somebody seated in the consultation room, just observing what is happening before the intervention is done and after the intervention is done. And one of the things that they will not do is that they will not interfere with the processes as they proceed. They will just be observing and documenting. Unless, just in line with WHO guidelines, they find something that is about to go terribly wrong. So for instance, somebody has prescribed an injection of 0.5 ml, but for some reason they didn't see the 0 point. So they see the 5 ml. So as an observer, you do know that this child, if they're injected with 5 ml, we are going to lose them in a few minutes. So that's the only time, and you must be qualified to be able to do that. The process mapping and time flow, as I said, as we introduce this, the way the patient flow is and how long people take at every point is very important for us to understand. And that is why we have this process mapping and time flow studies. We have the qualitative studies just to hear the stories from all the cases of the people involved, the mothers themselves or fathers for that matter, the healthcare providers, and even the in charges and the policy makers. We want to hear what do they say. So I am sure as Dr. Bashir was speaking here and Dr. Mulwa was speaking here, Maria there, who is in charge of those stories, was taking note and listening to whether there is hope in the future for these things to be adopted. We also have these key informant interviews with key stakeholders, and there is what Andolo's team is doing in the rest of the facilities, because I didn't mention that we are doing this in 17 facilities as the research. And then I talked about the cost and cost effectiveness. I don't know whether, Dickens, you have shown that part, the overview of the longitudinal study. Please bring it on the screen so that I can, yes. So that is the timeline for the study. We are starting with a small portion of 3 months. And then we introduce the 2 gadgets, and we are now in that period of the 3 months. Then we introduce those 2 gadgets, and then we follow for a whole year, for 12 months. That means that the first quarter will match very well with the last quarter. Are we together? So if we are doing this between October and December, the last quarter of the intervention period will also fall between October and December. So as we compare the two to see whether there is any impact and there is any difference in the way children are being managed and the outcomes associated with that, whether there is any difference, that's what we are going to do. And this is what is called a longitudinal study. That is what is happening in Kenya and Senegal, but in Tanzania and India, they're actually doing the RCT, the randomized clinical trial, where they have some facilities which have the intervention and some facilities that do not have it. But in Kenya, we are doing the longitudinal study in 17 health facilities, which have been selected from the 60 that Andola was talking about. So really what we are looking at, we approach caregivers, we have the children screened, we collect data at the first day, we follow up after 7 days to find out how the child is doing. And if they come back to the hospital along that period, we also get to see what is happening to them. We will also be seeking to collect data from where they are referred, in case they are referred. So the key output for UON is really this operational research and the cost effectiveness research, as it were. And the outcomes that we are interested in is appropriate referrals and hospitalizations, proper prescription for antibiotics, adherence to the IMCI guidelines using the ECDSA, and the cost effectiveness. Those are the key outcomes of interest that we are interested in. So where are we at this point? We started this journey in 2019. We had to come up with protocols because this is a very scientific process. And the complicated part of it is that it is in 4 other countries. And therefore, there is the overall body, the WHO, had to be reviewed at that point. They had to be reviewed locally. And at some point, we realized we even needed a license from NACOSTI, which we got. And, and now we are at the point of implementation. We are happily implementing the baseline. And we look forward to the day that we will complete the data collection and start crunching the numbers and start giving the results and talking to Kina Dr. Mulwa and the rest with evidence. So I will skip this slide because I've just explained where we are. The 17 facilities that we are in, for the people from the counties, we have 5 in Kitui, Kwavonza, they call it KV Health Center, Ngangani, Kasiala, somewhere on some hill, there is Thitha and Waita, somewhere in Wingi. We have 6 in Kakamega, Buyemi, somewhere in Kolomani, Shiseso. There's El Wesero Health Center, Nabongo. There's approved dispensary somewhere just in town, and Lumani dispensary somewhere in a very remote village. Then in Uasin Gishu, we have Soy Health Center. On your way to Moy's Bridge, we have Kapsoya, you have Kapkei, Queenet, Kaprobu, and another one called Chamngorol, somewhere near Bird Forest. So far, we have just about 3,400 children screened and are almost 3,000 enrolled. We had hoped we would be enrolling about 11 daily, but we are doing 5 to 6 every day. We've also been following them 7 days. And one of the things that personally I've realized is that we still have challenges with phone access in this country. There are many people, particularly in the rural areas, who do not have access to phones, and they have to rely with the neighbors or the shopkeeper or somebody else who has a phone when you are following up. So I want to thank the following: PAD headquarters and even the local office, Swiss TPH, who have been with us and working very closely with us to ensure that we are the same level with the other countries, the University of Waterloo, Unisante, which is the one that has converted the IMCI guidelines into electronic format, MOH here, the county health departments of Kitui, Uasin Gishu, and Kakamega, and actually the University of Nairobi leadership, where we operate from. They have given all the necessary support that we needed for this project to succeed. Asanteni sana.
Thank you, Mr. Francis Jiri, for that insightful. Now we have known how many children have been screened. I did not know about that one. So at this time, I want to open up if there are any questions, Q&A session for the presentations that we've had, then they can be responded to. Any questions? Something which is not clear? Or I'm talking to the converted. The people who already understand what we are doing. Any questions, any discussions, even from the counties? Here is the time. The bosses are all here, the representatives of the project. So if you have any observation or any concern or just something, or even sharing, which you can share with the whole team, then this is the time. I look left, I look center, and I look right, and there seems to be no question. That means that all these people are converted already, they already know, they understand what the project is all about. And I think the best I can do for now is just to call in whoever is giving us the vote of thanks to come up and give us the vote of thanks. And I felt, since this is a joint effort between the Ministry of Health at the national and county levels with our partner PATH, then it would just be good for PATH also to come here and give us a vote of thanks. So PATH, who is doing it? Dickens. Somebody else. Okay, thank you. Okay, one presentation. Who is coming? Joshua from, okay. From where? Eugene. Okay. So I'm told Washingishu want to share the experience. Washingishu, Joshua, please come up and just share before we go to the vote of thanks. Thank you. Welcome.
Distinguished guests, ladies and gentlemen, good morning. Apparently, it seems I was almost forgotten, but I am here to speak on behalf of the 5 facilities that have piloted this program. The pre-pilot for ECDSA and pulse oximeter is ongoing in the three counties and 5 sub-counties, that is Kilingili Health Center and Savane in Kakamega County. We have Chepterit Dispensary in Uasin Gishu, where I come from, and Kitui, we have Wanzua Dispensary and Miambani Health Center. So the sentiments I'm going to make here are evidence-based on what we have experienced in our facilities since we started using the ECDSA and the pulse oximeter in seeing the children. So the use of pulse oximeter in the facility has improved the level of care and treatment and in the management of children in our facilities. Now with the introduction of pulse oximetry, all vital signs are monitored and recorded. Previously, we would just go over the basics like the temperature and see the children, but with the introduction of ECDSA and the pulse oximeter, we are now able to capture all the vital signs necessary to be able to come up with the correct diagnosis. Now, severely sick children are able to get immediate attention. in most cases, without the pulse oximeter, we would overlook, or rather we would not be able to get the attention to get timely referral. And with the pulse oximeter, we are now able to capture children who have pulse oximetry of below 90, and this indicates severe illness which needs urgent intervention. Some of the challenges that we have had is it becomes a little bit difficult to ascertain the values in an irritable child and changes of, we have challenges in charging. We have facilities that have fluctuation in power. And so sometimes the outage goes for days and we're not able to charge the pulse oximeter. We would also like and would feel comfortable if temperature and respiratory rate was captured in the pulse oximeter to reduce the waiting time of our clients. In the use of CDSA in the facility, CDSA has introduced comprehensive assessment, diagnosis and treatment of the children in the facility. We've been able to identify delayed milestones, which was easily missed when we did not have something comprehensive. We also have had a great improvement in identifying usually missed classifications like malnutrition, and it has assisted in calculating the correct dosages for pediatric drugs, because the ECDSA calculates for you. Once you've inputted the age and the weight of the child, it calculates for you. It has assisted us in identifying children who had missed vitamin A and the supplementation for deworming. There's also have been improvement in quality of counseling of caregivers and their children. I am really glad, because personally I have been able to, at some point we used to issue antibiotics without, even where there is no need for an antibiotic. But with the ECDSA, you are able to, it gives you points on how to counsel the mother on why you do not need an antibiotic in this situation. For example, common cold, we would find you would give a Moxil, an antihistamine, and probably paracetamol. But even in some cases, what they only need is counseling on what to do without an antibiotic and even without an antihistamine. So it leaves, the ECDSA leaves no part untouched in the assessment of the children. Thus, this has given us as healthcare providers great insight in identifying the needs of my patient. It has enabled the healthcare provider to give the right pre-referral treatment for children with severe conditions, hence minimal time consumed as compared to previous times and scenarios where we ought to have consultations and referral from guidelines to make the right decision. Now, some of the challenges that we've had, the major challenges was initially transforming from the manual way of seeing our patients to the digital way. Speed was also an issue. You see, when you're using a tablet, you've got to input, but I can stand here and say, with time, you realize that you also adapt to it very fast and the speed improves. It's actually much better than when we were doing it manually. We would also, I think we had raised this and said, all essential medicines used in the management of children need to be captured in the ECDSA so that everything flows on well. Thank you very much.
Wow, sorry, I wasn't in the last presentation. But at this time, I want to, is there's any question? Parents, you're asking me something, say it now, or forever you keep your quiet. It's like he had a question, so let him say it now. Or you keep your quiet. Let me bring you.
Thank you very much, Elsa. My name is Paris Mukami from the Ministry of Health. Mine was not a question of just saying we needed to hear some bit of experience, particularly the one that had from the implementing county. Because we've had challenges that we come up with quite good initiatives, but there are challenges of rolling them out in the counties. So the experience we just heard now from Wasiligisu is telling. We hope the 3 counties will give excellent examples so that the rollout, so that the gains can be realized countrywide. I'm sure there will be benchmarks in the 3 counties, particularly as we now want to see really where the ministry can be taken upon implementation of this water food initiative. And I think the 3 counties, like we have seen today, will have to the task to take us there. Otherwise, mine was not really an excellent answer. Brought me to appreciate and also to insist that the implementation at the 3 levels be excellent as a benchmark for them. Thank you.
Thank you, Faris, for that. So colleagues, we want to recognize a very special group, which is with us here, the people who actually do the work, the ones who work with the algorithm, the clinical decision algorithm. They are the ones who will determine the success of this program, of this project. So from the health facilities, Kitui, just raise up your hands, the ones from Kitui Health Facilities, the ones that, thank you so much, Kitui. Kakamega County, the people who really are on the ground, wale watu kwa ground. Thank you. From Uasin Gishu, wale watu wa mashinani kabisa. The ones on the ground. Uasin Gishu, thank you. When you go back, greet for me, Mandago. So, so thank you. So they are the ones actually who will make this program to either succeed, because if they develop any issue with it, then we have lost. So at this time, before I invite the one who is going to give us the vote of thanks, for me, as I conclude as your MC, holding brief for my colleague who was unable to be here, I just stepped in at 9 p.m. last night. So that's how fast it was. So I want to take this opportunity just to thank you. But one take-home message, and probably when you are coming as expectation, was to innovate, do something differently to help save that child. So that is why we are here. And this is actually a calling. You can see from the way I speak, I'm very passionate about children. I don't know, because I'm a mother, I'm a grandmother, I'm everything about the child. So without much ado, let me call my colleague. I said it's partnership, MOH part, to give a vote of thanks. And thank you so much, my colleagues from the counties. When you go back, we will be seeing you shortly as we come round for supervision. Let me recognize my friend here, Wilson. A great guy, a great friend of ours from the research. So Pat, who is giving the vote of thanks. Thank you, Pauline, for your support. Thank you so much.
Don't worry, it's not a presentation.
Good morning, everyone. My name is Pauline Irungu, and I work for PATH, and I'm responsible for leading the advocacy and policy work for the office here in Kenya. So I want to recognize that it's been really a wonderful morning launching Tmci. We've been on the ground doing work, but it's good for us to bring this project to be widely known by critical players in public health. So let me start off by thanking our mother ministry, the Ministry of Health, for a few things. One, supporting the idea that PATH and its partners placed on the table. I think it was about 2019, and giving us the go ahead to work in this country. Unless government says yes, we don't move forward. Also for the partnership to work alongside government, both at national and county level, to improve outcomes for children. We are really grateful for that. For the leadership, Dr. Mulwa was here, Dr. Bashir, Dr. Mwangi, and for the staff at the DNCH for all your support, collaboration, and working alongside in many, many different ways. To the counties, Uasin Gishu, Kitui, and Kakamega for their support, collaboration, and opportunity to work with the leaders, but also with health facilities and healthcare workers to test the tools that we are advancing through Tmci for treatment of children, both pulse oximeters, as well as the electronic clinical decision support tool. We are very grateful for your willingness to walk this journey with us and for enabling us also to gather evidence, to document your experiences so that we can shape the policy direction that this country takes forward. We particularly want to thank the healthcare workers. Elsa has singled them out for agreeing to test something new and move away from what you do usually. When something new comes, sometimes it looks like work. But my entrepreneurship teacher many years ago told me that opportunity comes dressed in overalls and looks like work. When it passes, you don't catch it. So thanks for catching this one. To our partners, the core partners of this project, University of Nairobi, Swiss TPS, Unisante, for really driving this work forward, and also to United for providing financial support to enable us to move this work forward. And to all child health partners in this country and beyond, who remain committed and keep the promise. I hope you remember that statement, keeping the promise. How many years are we celebrating keeping the promise on improving the health and well-being of children? Asanteni sana, enjoy the rest of your day and God bless you.